Hello and welcome. My name is Raj Persaud and I'm a psychiatrist based in London. I'm in conversation today with three young psychiatrists in training, Amanda, Aria and John. And they're going to be telling me a little bit about their experiences of starting out in psychiatry. So Amanda, let's start with you. Could you say a bit about yourself and where you are in your psychiatric training?
Okay, thanks, Raj. My name's Amanda, and at the moment I'm working in Liaison Psychiatry, and I'm about to start ST4 in General Adult Psychiatry in February.
And for people who may not know, what is liaison psychiatry?
It's providing psychiatric services to the general hospital, so looking at how the interplay between physical health and mental health, really.
So could you give us an idea of what kind of patient you might see?
So we see people who might have medically unexplained symptoms, so symptoms like pain, which don't have a identified medical cause, and we see people in A&E, for example, people who have harmed themselves. And we also see people who have psychiatric problems and also physical health problems. So, say people who have depression, which might come on as a result or in conjunction with physical health concerns like diabetes.
That's very helpful. Aria, could you say a bit about yourself and what you're doing in psychiatry?
Well, hello, Raj. Thank you. Well, I'm a dual trainee actually. I'm training in both adult and old age psychiatry in a city hospital. And at the moment, I'm in ST5 doing a placement at the PQ, that is a psychiatric intensive care unit.
Could you say again a bit for people who may not know what that means? What is a psychiatric intensive care unit?
I guess I can akin it to any other intensive care unit, but obviously this is specifically for psychiatric patients. So it's patients who are of higher risk, either due to the acuity of their illness, or maybe because they're more aggressive, or they have a high risk of either self-harming, or they just need a rather low stimulus environment. So it's a smaller ward with a fewer number of patients with a high staff ratio. So as a result, and that's a psychiatric intensive care unit.
So some people might say those are patients who, for example, might be described as floridly psychotic, people who are actively hearing voices and have unusual or strange ideas, and that they're acting on those ideas. They're quite difficult to be with as a result. Would that be the kind of person that you might be treating, or is that not a reasonable description?
Oh, I think that's a very good description, actually. That would be the majority of our patients. And the minority, the other patients would comprise of, let's say, patients who are very severely depressed and extremely dependent on nursing staff and thus need nurse, a bigger nursing input. And they are better managed in like as I mentioned earlier, a low stimulus, a quieter environment. But because we have fewer patients and generally the same ward area, we can manage a patient who needs a quieter, low stimulus environment and needing much higher level of input. So we've got,
So would a lot of those patients, sorry to interrupt you, would a lot of those patients be involuntary patients? They're placed under a section of the Mental Health Act, so they're not there, they're there against their will, as it were.
yes, if a patient is in the intensive psychiatric intensive care unit, they will always be under the Mental Health Act because the ward is a locked unit and most patients would not have leave, or in other words, the ability to leave the hospital, and would also be very closely observed. They would need to be detained under the Mental Health Act.
That's a very helpful description. So finally, John, we come to you. Could you say a bit about yourself and the kind of psychiatry that you're doing?
Yes, I'm currently an ST4 in general adult psychiatry, having worked in different specialties. My current placement is more of a rural placement, so my work is mainly outpatient based at the moment, as well as my on-call work, during which I'll see obviously patients of various ages in the hospital and outside.
So all of you have used this term ST something or the other, ST with a number. Again, for people who are not aware of what that means, John, could you explain what an ST4 is?
So it just stands for specialty trainee, and the number is the year that you're in. So, for example, people will do their foundation year training, which will take up 2 years once they've qualified as a doctor. And during those 2 years, you'll rotate through various different specialities of medicine. And then after those 2 years, you choose what you would like your core training, which would be your CT training to be. And obviously the three of us have chosen psychiatry. So you do 3 years as a core trainee, and I've also done another couple of years as a staff grade doctor before then joining the specialty training, which is ST.
So I wanted to go back to you, Amanda. Could you say a little bit about why you chose to do psychiatry and how you chose it? Was there a particular moment when the idea arrived that you were going to pick psychiatry, or had it been along in development?
Well, I mean, that's a really big and kind of complex question, and I think there's a huge amount of sort of perceptions of a specialty and experiences which kind of influenced my career decision. It certainly wasn't a sudden moment type thing, but I guess for me, the decision was really strongly based on some of the experiences that I had at medical school, and particularly in one rotation, we did neurology and psychiatry together. And I remember actually seeing people in the neurology part of the rotation in a Parkinson's clinic. And one person in particular kind of stays with me, this man who we discussed his symptoms, and I was thinking, you know, this guy, he's obviously got Parkinson's disease, but actually his symptoms don't seem as severe as a lot of the other people in the clinic, and yet he seems to be affected by them hugely, and probably more than some of the other people that we'd seen in the clinic. And I kind of thought, well, why is that? But there wasn't really time in that environment to think about it, and you just kind of went on to the next person and just looked very strictly at the symptoms that you were there to treat. And it was just so contrasting to psychiatry, which I was doing in parallel, where I was on a low secure unit where people were just in for ages, it seemed, and you had really had the opportunity to kind of understand a person's narrative, which was really interesting, especially as a medical student, where you didn't really get to spend huge amounts of time with patients otherwise, and you got to see someone and understand them as much more as a person, not really that much different from you. And I guess that those contrasting experiences just made me want that opportunity really to see people more holistically rather than seeing them as a specific symptom. And I guess that's one of the things that I hope to get from pursuing psychiatry as a career.
And Aria, was it like that for you?
Well, I would say, like Amanda, I actually got interested in psychiatry in my fourth year of medical school. But instead of the psychiatry attachment, it was actually the special study module, which I did in camps, that interested me. I remember seeing I remember seeing a lot of young kids with severe autism.
Because CAMS means child and adolescent mental health services.
Yes, of course. Yeah, sorry, child and adolescent mental health. And I just remember seeing so many young kids with severe autism and the impact it really had on them, the schooling, and the parents. And also because when you work in child and adolescents mental health, you go to schools and you see the impact it has on the other kids and the teachers as well. So that really stayed with me until I did an F2 placement in psychiatry, which was at the beginning of F2. And towards the end of F2, it struck me, of all the patients I'd seen in F1 and F2, that is Foundation Year 1 and Foundation Year 2, it was the patients I'd seen in psychiatry that had stayed with me, namely some of the young patients who'd had schizophrenia, chronic schizophrenia, and were really affected by it. and also thinking, and I remember thinking back when I was applying for different jobs, thinking that was actually the one job that I really enjoyed, waking up and going to work on a Monday. I used to look forward for Monday on a Sunday, and you don't often get that.
And why did you look forward to it, though?
I guess it was mainly the interaction you have with the patients. You really get to know them. And in a large sense, you're more than just a doctor that goes and asks them their symptoms. Um, I found a lot of them do confide in you. It's probably one of the few people they actually have an open conversation with. And another thing that thinking back, I enjoyed then and I continue to enjoy now is the general ward environment in a psychiatry unit. When I go to a medical ward, I see the massive difference in the sense we will have a living area. You could see the patients, they engage with you. They actually have a good rapport with you to start a conversation as opposed to the general ward round of how are you, what are you doing, are you still in pain? Um, and I guess I like that. I like the fact that I can have a in-depth conversation with with my patients, really getting to know them and a lot of their personal history as well. And then through that conversation, I know that I'm making a difference because you see how especially in the psychiatric intensive care unit, I see how unwell the patients are when they come in. And it's really fulfilling to see them leaving the unit being able to, function very independently.
So, John, it sounds like for Aria and Amanda, there was something about getting to know people in a more in-depth way that was part of the attraction of psychiatry. What about for yourself?
Well, I think even prior to medical school, psychiatry had always been something that I was quite interested in, but didn't really know much about. And similar to Amanda and Aria, my first experience with a psychiatric patient was in my fourth year attachment as a medical student. And I sort of quite clearly remember seeing a patient with mania and just being absolutely fascinated as to it was something I'd never seen before, and I wanted to understand what would make someone sort of act and behave in that particular way. And I guess it really struck a note with me that other specialties hadn't throughout my medical training. And I guess similar to both of the girls as well, I then went on to do a foundation job in psychiatry. And I guess backing up what Arya said, it is that the rapport that and the relationship that you form with your patients that is very rewarding in psychiatry, and I think it's very unlike any other specialty where you have such a long period of time and you really properly get to know someone, and they will confide their deepest darkest secrets to you that they might not have told anyone else, and it's just a very rewarding specialty from my experience.
So I'm going to throw this open to anyone to come in on. I'm not going to direct this at any particular person, but it's a bit of a provocative question in a way. But would you say, any of you, that the kind of person who ends up choosing psychiatry from medical school, in a way, already is a different kind of medical student to the kind of person who wants to go into surgery or wants to go into the kind of specialty where you jump up and down on someone's chest, ER style, and bring them back? In a cardiac resuscitation, a kind of emergency type scenario, or very interventionistic scenario. Do the kind of people who choose psychiatry, are they different already? Can you spot the difference at medical school or even before? Anyone have any thoughts about that?
I'm not sure that you can, or whether it's part of your experiences as a medical student that kind of makes you a particular sort of person. I guess there are things that you probably characteristics that make people suited to a specific specialty, but I don't think that any individual could absolutely not do a different specialty. Like when I was in my foundation years, I did orthopedic surgery and I really enjoyed it, whereas a lot of the time you might assume that that's completely different. But I guess perhaps if you have certain preferences or certain ways of working with patients, then perhaps that does suit a specific specialty, or perhaps actually that can be sometimes a quality on a team where other people have different traits. For example, if you take a lot of time over each of your patients, then you might not be so suited to specialties where the throughput is much quicker, because you have to balance that with providing the service that is required of the specialty. But I think a lot of the skills you can kind of learn, and that is one of the purposes of medical school.
But in the same manner, sorry.
Yep, go ahead, Aria.
No, but in the same manner, I do think there is some difference in the people who go to different specialties. Like Amanda said, I do agree there's a lot of stuff that you learn in medical school, but I also know some colleagues who would say yes, if they had to do, if they were to do a psychiatry attachment or a job, they would probably not enjoy it at all, because it's just not in their nature, as as they would put it. They're not interested in getting to know the patient. It's more about, they're more interested in, if example, if it's surgery, in the operation per se. But saying that, I think if you're in medicine, you're in a profession that you care quite a lot about people, and you do have to get to know people to some extent. And I think it's a skill, like Amanda said, that you can develop. But I think you have to have that wanting to develop that skill and gain some enjoyment. I think that's the difference between doing psychiatry and enjoying it versus just doing psychiatry and getting through an attachment.
And John, any thoughts?
I mean, I suppose I guess your interest in psychiatry can be quite highly influenced by your experience of it and your understanding of it, which I suppose will be topics that we'll come on to later. But I mean, I've seen people who've not really been interested in psychiatry as a student, who've then gone on to be GP trainees, and then they've done a job in psychiatry and actually found that it was their preference. They've once they've got into it, they've actually enjoyed it, and then gone on to choose that as a specialty. And equally, you see people who, as medical students, just simply, as Aria said, don't have an interest in psychiatry and don't want to work in it. So it's a difficult question to answer, really.
And I
Do you
guess
think?
oh, sorry.
Well, do you think there might be misapprehensions or misunderstandings that people have within medicine and outside of medicine that put people off thinking of psychiatry as a career? And I'm going to throw out some rather provocative possible misapprehensions. And these are going to sound terrible in terms of stereotypes, but I'm going to bravely try and say them because I think they are out there, and I'm interested in your opinion. One is classic stereotype number one: no one gets better in psychiatry, or you're only dealing with dangerous people. And it's very unrewarding for various reasons. And you end up working in some very difficult, underfunded, very stretched services. Any thoughts about any of those stereotypical views?
I think on the third point, you're working in underfunded, overstretched services in whatever specialty you go into. That might be kind of cynical, but I don't know that that's a particular problem in psychiatry specifically. And I guess in terms of the other sort of preconceptions, I think the kind of danger thing is something that comes up quite a lot. Like when I've been talking to medical students quite recently, there's a real idea that actually when we come into psychiatry, we're told, oh, forget your preconceptions, forget all your kind of stigmatized attitudes, that people with mental health problems aren't dangerous and all this, and then we're given alarms to go onto the wards. And I can see that there is sort of a conflict there, which if you're quite naive to the sort of issues, then perhaps you would perceive this sort of uncertainty, and that might put you in a situation where you're not particularly easy. And it's about how we kind of explain that and how we address that, I think, with medical students. And I suppose for me, when I was doing my psychiatry placement, I didn't feel particularly uneasy about that. To be honest, I don't know really that it had particularly was something that I thought about as a medical student, but certainly it's something that perhaps is something that we tell medical students. It's more on the agenda now in terms of maintaining our own safety. I'm not sure.
Amy, I guess working in a PQ, I hear about this a lot. But one thing I can say is, I work in a male psychiatric intensive care unit, and at no point have I felt threatened or worried about my safety at all. And I would agree with Amanda when I say, when Amanda said, yeah, you weren't too worried, because I can't remember being too worried about my safety until actually I was told about it by the service saying, oh, you need to have the alarms, etc. But I do wonder if that's part of the risk averseness of the institution as a whole, as opposed to the patients, and of course that feeding into the misperceptions of the patient. I know that's a rather controversial thing to say, but it's something I wonder quite often. Because if you look at the statistics per se, there is no increased risk of aggression among psychiatric patients than other patients. As a matter of fact, I think if you work in an old age geriatric ward with patients with delirium, you're more likely to face patients who are aggressive towards you than on a psychiatric ward.
And John, do you have any thoughts?
Well, I suppose I could maybe try and address one of the other questions that you asked. The first part was, do we feel that we're treating untreatable patients? Was that the first part of the question?
That's a stereotypical view that when I was a medical student, a lot of medical students held, the view they held, I think.
Yeah, I think that's probably quite true of nowadays as well. I think that, however, you find when you work in psychiatry that it is a far more rewarding specialty. I particularly remember one of my consultants giving a speech and asking us essentially what we felt our role was as psychiatrists, and he gave an interesting example of asking the audience when was the time that you felt someone had properly listened to you, and we were then supposed to think about a time when we'd been stressed and had a conversation with someone where someone had listened to us, and the question was then posed to us of how did you feel before the conversation compared to how you felt afterwards. And I remember running this through my head and thinking of an occasion when I'd been in that situation, and having someone listen to you makes such a profound difference to the way that you feel, that sometimes, when you are in A&E at 4 o'clock in the morning and someone comes in who has a lot of psychiatric problems, you might not be able to solve the life problems that they've had, but as long as you can make a difference to how that person feels, it can be an extremely rewarding job, psychiatry, in terms of that very acute difference. But then also I feel, as Arya said, when you see patients on a PICU or a more intensive care unit, you might treat them for a longer basis, and as Arya says, get people back to functioning independently or have an improved quality of life, that again can be very rewarding. So it is I think you're right, it is a perception that people have, but I think at times it's an incorrect one.
But the other thing that I'm interested in your opinion, all of you, is the fact that I think it is a very different specialty from most of the other specialties, in the sense that two big senses, and I see this when I go to seminars like cardiology seminars or orthopedic seminars. First of all, the technology in the rest of medicine is just stunning in terms of the images people get and the kind of investigations they can do, and the sense of progress all the time, scientific advancement. And then the treatments are also very exciting in the rest of medicine in terms of the technology and the advances. And then you come to psychiatry, and yes, there are advances, but you just don't get the same sense that you've got shiny buttons to press and activating new technologies. But I don't get a sense from any of you that actually that you would necessarily agree with that assessment or that bothers you.
I guess
Anyone can chip in on that.
I guess it comes down to what you get satisfaction from. And I think that when you asked us that first question about what drove us to do psychiatry in the first place, none of us said, oh, it's the, the medication or the technology. It was really getting satisfaction from kind of understanding where a person's coming from and understanding them in a kind of holistic manner, and sometimes supporting people who are otherwise quite marginalized really in society. Whereas if you're somebody who gets a lot of satisfaction from seeing a problem, fixing it and letting the person go home, perhaps it wouldn't be kind of the specialty for you. But I think there's a lot of other reward from knowing a person and having that opportunity to understand them in a much wider sense.
John or Aria?
I think I'd probably agree with what's been said so far. I think the fact that there's no sort of magic test to diagnose psychiatric patients or a magic cure, I think is almost one of the reasons why I enjoy it so much, because it's not so black and white. You have to see the sort of grey or the as Amanda said, you're going far more into the sort of the background nature of the patient, and it's just a more, as I say, less black and white. I think that it's quite interesting for myself anyway.
I mean, like John and Amanda says, I guess for me, the fact that there isn't a strict diagnostic test as such, it actually excites me, because that I find it a lot more intellectually challenging. Because you have to, like John mentioned, you have to look at the gray area, but you've actually got to take a step back and analyze and look at the situation. Because rarely in psychiatry can you follow a set protocol or a treatment pattern, because patients just present in so many different ways but have the same diagnosis. But saying that, I guess the use of investigations completely depend on the specialty that you do as well. For example, if you do liaison psychiatry or old age psychiatry, then I think you actually have to be quite up to date and up to speed with the different medical conditions and the investigations that are used. For example, in dementia, there's more and more use of CT brain scans and MRI scans and DAT scans. And in the more specialist units, we are using perfusion scans as well. So I think the point is psychiatry is such a young specialty, and it's still growing quite a lot. And maybe in a few years' time, if anyone's very keen on using investigations for diagnosis, there will be a place for them. But that's what's great about psychiatry. You can actually grow with it and learn all of these new things.
Okay, so you're at a dinner party, and we get to the stage where people start saying what they do for a living, and someone says, I'm an orthopedic surgeon, another one says, I'm a barrister, someone says they're a dentist, and then it comes to you. Do you say you're a psychiatrist, and what happens? Do you find that there's a stigma attached to being a psychiatrist? Do you find that people start behaving towards you differently? Does it make people nervous when you say you're a psychiatrist? Does anyone have an experience or a reaction to that question?
I guess.
Sorry, you go on, Amanda.
John, go ahead, John.
I was just going to, I guess, before I give my reaction, I was speaking to my partner this afternoon to ask about what her experience of this was. And she said that when she explains to people that she is in a relationship with a psychiatrist, the stereotypical reaction is one of, and then drawing a breath, and then, does he psychoanalyze you? Followed by, it must be, inverted commas, crazy people that he deals with. And I think some of those reactions are quite common when you yourself say that you're a psychiatrist as well. People, again, I think this varies wildly with people's experience of psychiatry. But I think people who don't have a massive experience of psychiatry do instinctively ask you questions like, do you psychoanalyze all your friends? And the various stigma come up. I suppose that's some of my experiences. But equally, when you come across someone who does have an experience of psychiatry, it does seem as though they're far more understanding and aware, and they don't hold those stigma quite so close to their chest, so I think you get more open response. I'm not sure what the others feel.
I think Aria, you're going to chip in something there.
Yeah, well, I think John said it right. I think if people who have some experience of psychiatry or know about it, don't associate the stigma with it, that is stigma towards the profession. However, if you're not aware of the specialty, then there's a lot of stigma. I mean, I um, I'm from an ethnic minority where I guess the stigma towards the specialty is even greater than in the normal in the other rest of the population. And I remember when I first went into psychiatry, um, a lot of people kept asking me, "Why are you doing that? Can you not do any other specialty?" Some even said, "Do you realize you will probably go crazy, in inverted commas, crazy?" And but that's the stigma that's attached to the profession. But however, a lot of people now, when I go and talk about work, um, it's something completely different what they assumed it to be. Unfortunately, I think a lot of people still have the impression of psychiatry as they saw in the movies, such as One Flew Over the Cuckoo's Nest. But obviously, it's entirely different.
And
But
oh, sorry, go ahead.
sorry, Amanda. That's
Amanda, you go
Oh,
ahead.
yeah. I'm, to be honest, I'm not entirely sure about this idea that the more exposure you have to psychiatry, the less kind of stigmatized your attitudes, either towards people who do psychiatry or towards people with kind of mental health problems, because I think a lot of it depends on your individual experience of psychiatry at medical school. But I think stigmatized attitudes towards psychiatry as being almost a second-rate specialty are really rife amongst the medical profession. And there's some evidence to suggest that stigma through medical school actually increases rather than decreases. So I think we do need to kind of look at what are we teaching people? Why is that? Why does that occur over those years?
And I think that's something we would like to discuss again at some point in the future. But we can certainly talk a bit more about that. But I also want to get on to this issue, which I think Aria touched on, this view that's widely held that it's a very stressful specialty, more stressful than other specialties in medicine. And therefore, that may explain to some extent the sharp intake of breath that other people have talked about. I mean, what are your views about that? Was that a concern of yours, any of you? Did that put any of you off? Do you believe that it's a more stressful specialty than other branches of medicine?
I would say it's stress in a different way, but I won't say it's more stressful or more busy than, let's say, being a medical registrar. But I also would not say it's easy to see, let's say, 8 patients in one shift, 8 psychiatric patients in one shift, because you are taking a rather lengthy history, and the emotional stress involved is actually can make quite an impact on you. And you carry these stories with you at least for a while. I mean, a lot of the patients, some of the more profound stories, yes, I do remember them for years. And also, I think, let's say, examining or taking a history from a patient who is completely thought disordered is not as easy as taking a history from a completely cooperative patient who's coming to A&E because they've got chest pain. So it's stressful that way, but in the same manner, that's also what makes the specialty enjoyable. Because, like I mentioned earlier, for me, it's a challenge, and it's a nice challenge, and it's a challenge that involves me to lateral think, use common sense, and actually understand the patient as a whole. That's how I feel about it.
Yeah.
John, what are your thoughts?
Yeah, I suppose. I mean, I would agree with what Arya said. I think there are times when, I mean, I've worked in various different jobs around the country, some busier than others, and there are times, for example, when Arya said, if you're the psychiatrist who's covering A&E and you're seeing upwards of 8 patients sometimes in one shift, then it can be very stressful. But I think it's, in comparison to other fields of medicine, you're the stress is a different type of stress, I would say. If you had to look at a busy psychiatric job and compare it to maybe a busy job in medicine, I think the demands that are on you are entirely different. And both jobs can be stressful in different ways. But I think, as we've all discussed previously, it's a very rewarding job, and it's not always stressful. I think there's times when it's very enjoyable, and that, as Aria said, it's the getting down, getting to know someone, spending time with them, building a rapport and a therapeutic relationship that helps with that stress and helps. It's very rewarding specialty, I think.
Amanda?
I wonder if actually the perception of psychiatry as a stressful specialty arises because I think psychiatry is particularly stressful if you're inexperienced in it. And I think the reduction in stress with experience is probably greater than in other specialties, because if you are starting off in psychiatry, you might not feel confident in your ability to assess risk, which is something you're doing a lot of quite independently as a SHO, or sorry, as a kind of junior trainee. And unlike in other specialties where you have your team around you, even on calls where there's a higher trainee in the hospital with you, in psychiatry you're often alone to assess somebody who perhaps has harmed themselves, and there's a lot of pressure for you to discharge people, and that can be really, really stressful. But as you build up your confidence in that, actually you feel more able to manage that independently. And also you've got the stress of managing physical health problems on inpatient units without a great deal of direct support from your supervisors, who have kind of moved further towards mental health as they go through their training. But obviously the patients still have physical health problems, and there's a lot more expectation of the junior people to manage that, and you don't necessarily get the support that you would in other medical specialties. So I think actually where in other specialties perhaps it's the volume of patients that's stressful and the need to constantly prioritize, in psychiatry I think the volume of patients is actually a lot less, but the things you're being asked to do you might feel less experienced in and more uncomfortable with. And taking on the distress of patients, and for me certainly when there's kind of relatives that are very distressed as well, that can be really hard to manage. But I guess as you get more experience in psychiatry, that quickly, for me anyway, became a lot more easier, and I find it a lot less stressful than kind of other specialties that I've done.
Okay, one final question. There may be a medical student listening to this who's thinking about doing psychiatry but is uncertain, or maybe someone at sixth form who's thinking of going into medical school and maybe choosing psychiatry, or maybe someone even choosing their GCSEs, or maybe a doctor who is qualified and specialised in something is thinking of switching to psychiatry. I want to go round one by one with all three of you. What would you say to them about whether you would encourage them to come and do psychiatry? And if you would, why would you encourage them? What would you say is what they might gain from doing it? Amanda, should we start with you?
Yeah, I mean, first of all, if you're a student who isn't yet at medical school, then I think well done to you. I don't think I even realised that psychiatry was a medical specialty until I went to medical school, which is awful. But I think definitely consider doing psychiatry as a specialty, and I think you'll get a lot if you were to do kind of taster days, or if you were to do it as a medical student, really from that, and you'll get a much better idea if it is suited to you and if that way of working, you enjoy it. And I think for me, and this is something obviously I've already said earlier in the podcast, that I get a lot of satisfaction from understanding a person's narrative and working with them and supporting them to improve their quality of life. And if that's something that you value, and if you would value that kind of really privilege, really, of understanding somebody else and understanding people from a huge wide range of backgrounds, then I think definitely consider it anyway as a career, and do look into it further.
John?
I mean, I think I agree with the Amanda's use of words, the privilege, I think, that you have as a psychiatrist in the information that patients will give you is quite unlike any other specialty. I think my advice to people who are maybe junior medical students or people who have not had any experience of psychiatry would be to go in with an open mind. And I think it's quite important that how your first contact with psychiatric services comes about. And I think if you go in, I know Amanda was talking about experience making a big difference to your confidence in managing a stressful situation. And I think with your first experience with psychiatry, if it can be with an experienced psychiatrist who can show you a very interesting case and show you what could possibly appear to others to be a very stressful situation and manage it in a very calm and controlled manner, you can see how rewarding a psychiatric placement could be. And I would seriously encourage everyone to at least give it a shot and see what they think of it.
Aria?
Well, just like what Amanda and John has said, I would say I think the most important thing is if either if you're a medical student or a student in high school going into university, is try and get some experience, because I think there's nothing more valuable than the first-hand knowledge of the type of work that's involved in psychiatry, what it is like on the ward, and also in psychiatry, because there's such a variety of settings you can work in. For example, a rehab placement would be very different to an intensive care placement, again, very different to a community placement. And the other thing I would say to encourage anyone going into psychiatry is, there's something quite priceless or phenomenal about that in-depth knowledge about the person and getting to know them and working through their problems instead of relying on a test that will tell you, yes, this is the diagnosis, and no, this is not the diagnosis. And I also think working in psychiatry, you actually get quite a good understanding of yourself and the society and the social environment and the society you live in. And I think that's something quite unique to psychiatry, because I know I have myself grown on emotional level since I started doing psychiatry.
John, Aria, and Amanda, thank you all very much indeed.
Thanks.
Thank you.
Thank you.